This presentation is a collaboration between NHS Lanarkshire's Primary Care Improvement Team and Quality Directorate Improvement Team. Both teams have recently been involved in supporting NHS Lanarkshire's large-scale vaccination programmes, the 2021 flu programme and the COVID-19 vaccination programme. My name is Louisa Finlayson and I'm an Improvement Manager within the Primary Care Improvement Team, and I will present the first part of this presentation, looking at how the Primary Care Improvement Team supported delivery of safe, effective and efficient mass flu vaccination clinics. The second part of this presentation by the Quality Directorate Improvement Team will detail how using a range of QI methods and tools help staff in COVID-19 mass vaccination centres deliver quality and efficient patient experiences. The Primary Care Improvement Team are responsible for supporting the implementation of the Primary Care Improvement Plan. The aim of the Primary Care Improvement Plan is to oversee the implementation of the GMS contract, realising modernised, redesigned and integrated health and social care services responsive to the needs of the local population by ensuring the highest quality of care while in keeping with 7 key principles. A key priority of the plan is the Vaccination Transformation Programme, a review and transformation of vaccine delivery to reflect the complexity of vaccination programmes and changing delivery from GPs who were historically tasked with delivering vaccinations. The Vaccination Transformation Programme workstream that is the focus of this presentation is NHS Lanarkshire's 2021 flu programme. The flu programme was achieved through a joint approach by managed services, the school immunisation team, occupational health services, maternity services and health visiting. Managed services delivery, in particular, reflects the commitments made within the wider GMS contract to reduce GP workload, where vaccinations would progressively move away from a model based on GP delivery to one based on NHS boards delivering through dedicated teams. Managed Services has tested board delivery during the previous 2019-2020 flu programme, delivering to a small number of cohorts where real-time reflection and learning navigated the programme implementation. However, due to the COVID-19 pandemic, the 2021 programme was accelerated to include all eligible patient cohorts, and therefore, to successfully deliver this, a collective approach was required, where together the NHS board, GP practices, and a whole systems workforce were crucial in delivering the programme. The objective of the 2021 flu programme was to successfully deliver an effective flu vaccination campaign aiming to immunise the eligible population within NHS Lanarkshire through a whole systems approach during the significant challenges and impact of COVID-19. The Primary Care Improvement Team's role was to provide a full project support package due to the stage of the Vaccination Transformation Programme and the impact of the ongoing pandemic. Support was provided throughout the programme during initiation, planning, implementation and review. And this included an improvement manager, senior improvement analyst, project support officer and the communication and engagement officer from our team. The Primary Care Improvement Team supported managed services delivering to these cohorts by working closely with the operational group. And this session will reflect on the application of quality improvement methodology during planning implementation of NHS Lanarkshire's 2021 flu programme. There are 4 areas where we can manage quality and continuous improvement. Planning, by putting in place structures and processes to meet the needs of the population. Through control, monitoring quality and performance in real time, taking action when needed. Through assurance, by completing periodic checks to make sure the service is meeting the service users' needs. And through improvement, by solving complex problems by testing ideas and theories to improve the system. Utilising quality improvement methodology can help us to provide reliable, cost-effective and sustained healthcare processes, improving care delivery and enhancing patient outcomes. And an excellent tool is the Plan, Do, Study, Act cycles. that can be used to test ideas, trial changes, and assess impact. There are 5 critical components driving forward improvements, and this is being process focused, whether we are saving time, money, or improving quality of a service or system; being outcome focused, whether we're improving health status, attitude, knowledge; maintaining engagement with those who will be testing the changes; measuring through monitoring pre, during, and post quality improvement; and time, as it takes time to implement. Although a lot of the 2021 flu programme has required to be reactive due to the ongoing pandemic and many operational challenges that have been faced, we have still applied these QI principles in our approach through planning, implementation, and review. The reality of this real-time troubleshooting has meant that at times our approach has been unconventional. However, we have presented this below within the PDSA framework. Plan. To support initial planning of the vaccination clinic, we calculated and provided cohort population figures. These calculations informed staffing requirements, patient appointment allocation, and clinic operational hours. We held a vaccination administration timing workshop with key steering and operational group members to measure vaccine administration cycle time and consider clinic efficiency whilst ensuring patient safety and compliance with COVID-19 guidelines. We carried out several time and motion scenarios, and after acknowledging variables that could potentially take up additional vaccinator time and limitations of the allocated appointment system, the patient appointment times were set to 7.5-minute intervals. Through carrying out this process, we also identified additional key roles for clinics to support optimum patient flow and clinic efficiency. And to understand the system prior to implementation, we developed process maps of the patient journey through the mass vaccination clinic, taking into account patient screening of COVID-19 prior to entering the clinic, use of the one-way system, physical distancing requirements, IPC requirements, and consenting processes. The programme itself was led by an operational group made up of subject matters from locality management, public health, service managers and operational service managers, planning, practice development, pharmacy, general practice, nursing leads, and the primary care improvement team. Do. Patients were scheduled and appointed to the clinics, and the clinics went live. Following implementation, ongoing operational disruption was identified that was caused by technical issues with the national appointing system. Therefore, patient appointment allocation times required to be recalculated. This was completed and appointment times were changed to 5-minute intervals. We then submitted a project charter to observe the utilisation of this new appointment time, carrying out time and motion study, gathering real-time data and assessing clinic efficiency and safety, reviewing patient appointment capacity, and we produced a quality improvement observational exercise report following this. The report found that patient safety was not compromised by having reduced the appointment time interval to 5 minutes. There was also a review of the flu vaccination clinic DTEX reports, which was carried out by senior operational staff, the results of which will hopefully shape future vaccination training and clinical audits. Study. We carried study throughout the programme implementation, and through this we did monitoring staff feedback. To monitor vaccination uptake within the cohorts, each clinic was required to complete a SMART survey. Within this, there was a free text section where staff could leave comments and provide us with real-time clinic feedback. This highlighted to us what was going well, such as appointment timing, patient attendance, positive patient experiences, and team working. It also identified the kind of issues that staff had to troubleshoot on the day, such as documentation and staffing. And we also were looking at themes of where we could improve. And this brought up pre-clinic preparation time, the appointing and rebooking systems, and external signage. The evaluation team reviewed patient and staff experiences and produced a qualitative report highlighting that most patients were satisfied with their experience at this year's flu clinics, highlighting how helpful and pleasant administrative and clinical staff were at the clinics. And staff echoed this feedback that they had also received from patients at the clinics, one of which surmising that on the whole it had gone really well, but there had been some problems and glitches along the way. And we also carried out a direct staff experience survey, which identified scope for future improvements, and these related to planning and approach, clinical setup, communication, patient appointment system, staffing, and the clinical processes. ACT. Due to the nature of the programme, the PDSA process was carried out in real time, and test of change was at times carried out and then observed. It was identified that this could be continued to be implemented. We developed a suite of standard operating procedures. We introduced a patient safety brief. We continued to monitor feedback and programme progress. And we currently are finalising a reflective learning report to inform how we approach and plan future programmes. Monitoring. Data was collected and analysed throughout the programme, which provided essential, robust intelligence, particularly when public, local and national perceptions had raised concerns that delivery might not meet the needs of the whole population. Clinic data was recalculated several times during the course of the programme to reflect real-time learning, specifically to address the impact of lost clinics due to scheduling issues. Throughout the programme, a number of reports were produced that monitored the number of appointments scheduled, number of patients vaccinated to date, number of patients who did not attend for their scheduled appointment, number of patients who attended who were considered were not eligible to receive the vaccination, and the total number of opportunistic vaccinations given at clinics and by GP practices. And data within these reports was gathered from smart survey returns from vaccination clinics ran by managed services, Public Health Scotland reports taken from GPIT systems to account for opportunistic GP vaccinations, and the school's immunisation team population of a template provided by Public Health Scotland. Well, despite the many challenges faced and the ongoing COVID pandemic, by the end of the 2021 programme, managed services had successfully delivered 187,379 eligible patients, with uptake being surpassed for all three of the traditional cohorts. That's the 2 to 5 years, at risk, and 65 years and over cohorts. In the 2 to 5 year cohort, 11,504 vaccinations were delivered, which is 64.2% of the cohort population, and an increase of 19.8% from flu season 1920. In the at-risk cohort, 56,682 vaccinations were delivered, which is 57.2% of cohort population, and an increase of 17.6% from the previous year's flu season. And there were 104,894 vaccinations delivered in the 65 years and over cohort, meaning that 85.4% of the population cohort were vaccinated, and this is an increase of 13.9% on the previous year. This is a considerable effort from the operational team, locality management, and all those who worked at and supported the vaccination clinics, and this really needs to be celebrated. We were delighted to share our learning on the application of this QI methodology with the Quality Directorate Improvement team, sharing information and reports from our vaccination administration timings workshop, operational roles and definitions, time and motion templates, quality improvement observational exercise report, qualitative patient feedback and from staff and patients, feedback from staff on the front line, our staff experience survey, and our standard operating procedures. The second part of this presentation will be provided by the Quality Directorate Improvement team. And if you wish any further information regarding this half of the presentation, please get in touch with me directly or through the Primary Care Improvement team via email. And thank you for listening.